Welcome to Renal Scintigraphy, with special thanks to Tip Taylor and Adina Alazraki. This subject may seem daunting at first, so don't panic. If you learn the basic principles and remember to look at the images first and last, and that the curves and numbers only supplement the images, then you will have a good basic understanding of renal scintigraphy. And repeat your mantra of uptake, excretion, emptying. And we're going to be revisiting that mantra throughout this talk. Finally, this lecture should be reviewed a few times. Key papers are available on the Nuclear Medicine Division Education tab. And these papers will also teach you what you need to know. Let's start with the functional unit of the kidney. And understanding the path of the plasma to urine will help you in understanding how renal scintigraphy is performed. First, blood passes down the afferent arteriole to the glomerulus, and then it may be filtered into the tubule and then flow into the collecting system. If it is not filtered, it is possible to also have substrate extraction or transport from the efferent arteriole into the tubule and then into the collecting system. There are some substrates such as protein, which should not normally be in urine, and if proteinuria is present, this indicates parenchymal damage. So let's talk about the basic renogram before we even visit the concept of the radiotracers. The first part of the study, though not the critical element, reflects renal vascular flow in relation to the aorta. Let's play our dynamic imaging, and we could see that there is equal perfusion. Looking at our individual frames, the kidneys show up at about the same time as the aorta, and this is reflected in the time activity curves, in which the kidney time activity curves are close to and parallel that of the aorta. More importantly, what happens after that initial perfusion, which is uptake, excretion, and emptying, is what leads to best understanding of this exam. That is, uptake into the parenchyma, excretion into the collecting system, and emptying out of the collecting system into the bladder or other collection device, such as a nephrostomy tube to a bag or a ileal pouch, for example. Let's start with a normal study. Looking at our dynamic image, and then the individual frames, and the time activity curve. We're going to dissect each part of this study. First, uptake. Now, these are filmed at 2 minutes per frame on these individual frames. The uptake is into the renal parenchyma in the first 1 to 3 minutes. That is, before appearance of the radiotracer in the collecting system. It's typically reflected in the first 1 to 2 frames and this initial portion of the time activity curve. Then there is excretion. That is when radiotracer appears in the collecting system, and in normals that occurs after that first 1 to 3 minutes. We can see that in these frames and in this portion of the time activity curve where it peaks. Subsequently, there is emptying from the collecting system, and we could see that occurring in these frames. Now, in reality, the kidneys are excreting the whole time as well, but it's useful to think of this portion as the emptying portion. So let's talk about radiopharmaceuticals. There are many of them, and we're going to concentrate on the major ones in clinical use. There are 3 broad categories. First, those filtered by the glomerulus. Second, secreted by the renal tubules. typically involving the organic anion transporter. And third, those retained in the renal tubules, typically by receptor-mediated endocytosis from the glomerular filtrate. First, there is Tec-99m DTPA. This is a glomerular filtration agent, and it can actually be used to measure GFR. Typically, we administer about 10 millicuries IV, but one can do a nice job with about 2 to 5 millicuries, and this is in an adult. The extraction fraction from the plasma to the kidneys is approximately 20% with this radiotracer. Now, this is lower than the tubular agents we'll also be discussing. This radiotracer is the lowest cost, and the organ receiving the largest radiation dose is the bladder. Second is MAG3. This is a tubular secretion agent, and it's removed from plasma by organic anion transporter in the proximal renal tubules. Also given in about 10 millicurie IV, but one can also do a nice job with less radiotracer. This mirrors, but not exactly reflects, effective renal plasma flow. The extraction fraction of MAG3 is more than twice of DTPA, about 40 to 50%. So it's best for obstruction and in examining kidneys with impaired renal function, and it's used in about 70% of renal scans in the US. It is more expensive. Also of note, a small percent is excreted via the biliary system, so if one gets delayed views, this can show gallbladder or bowel, so do not get confused by that. The organ receiving the largest radiation dose is the bladder. Finally, the third major radiotracer is DMSA, and this is a cortical retention agent via receptor-mediated endocytosis. About 40% of the injected dose is retained by the renal tubules. This is given in an adult with about 5 millicurie IV, and there is more appropriate dosing in children where it is primarily used to evaluate relative function, pyelonephritis, and renal scarring. And because it's retained in the kidney, the organ receiving the largest radiation dose is the kidney. Now, there are other radiotracers, such as glucoheptanate, which reflects cortical retention and GFR, but this is little used in the United States. And if you want to read about all of these different radiotracers, you can look in a textbook or the comprehensive papers on our website. So there's some key information you should know about doing renal scans. First, that hydration is important. If a patient is dehydrated, this can mimic renal dysfunction. Also, if the patient is hypotensive, this can lead to a false positive study. And finally, confounding effect from a full bladder can look like obstruction, so you want to have the patient void before starting the study. You also want to know where the kidneys are located. This study is typically imaged posteriorly, but if there is a pelvic kidney, which is relatively anteriorly, one will need to modify the protocol to be able to image that kidney. Also, is there a percutaneous nephrostomy in place? And the question is, should the study be done with the tube clamped or unclamped? And this comes down to why you're doing the study. If there's a known obstruction and you want to see if the kidney is functioning and worth saving, you're going to do the study unclamped. In other words, you don't need to prove again that there's an obstruction. The urologist just wants to know if it's worth saving the kidney, so they're looking for function. But if there is a treated obstruction and the urologist wants to know if it's safe to pull the nephrostomy tube, then you want to clamp the tube, because that will best simulate what happens when the nephrostomy tube is pulled. You also want to know if there's a neobladder or ileal conduit. The patient may need a Foley in that case to ensure free flow out of the conduit If the patient has a bag, you want to ensure free flow into the bag as well, and that it doesn't cause artifact in the study. These patients often self-catheterize. Also, know that ileal conduits often reflux, so you want to carefully examine the dynamic images and don't confuse reflux with pathology. And if there's a known bladder obstruction, then you want to put a Foley in, because again, you could simulate renal collecting system obstruction as well. So what are regions of interest, or ROIs, and does it really matter? And the answer is yes. Accurate ROI placement is critical in getting meaningful and consistent results. So look at the ROIs and know where the text draw them. It should be on the images and what is recommended by the processing program. All it takes is a quick glance to see if something is off. A whole kidney ROI will encompass the parenchyma and collecting system. But parenchymal function is best assessed with cortical ROIs, and then you want to avoid the collecting system for accuracy. If you want to look at emptying, you can draw an ROI around the collecting system itself, or just use the whole kidney ROI. So if you remember two regions of interest, remember whole kidney ROI or cortical or parenchymal ROI. Note here that the collecting system is excluded from the region of interest. There is another region of interest to be aware of, and that is of a background. So why is it important? Well, first, as far as how these background regions of interest are obtained, many times the software will just generate these automatically, and perirenal is the best. But some software will make the tech draw these manually. The bottom line is to ensure that high activity from the collecting system or other organ is not included in the background, or this can confound split function analysis. So I'm going to prove it to you. The equation for the split function is activity in kidney 1 minus background divided by activity in kidney 1 minus background 1 plus kidney 2 minus background 2. So, just think about it. If you spuriously elevate that background 1, it will decrease the numerator, which will decrease the split function. So here, for example, is a well-drawn regions of interest in a study with good backgrounds. Now, this background happens to overlap the liver a little bit, but it seems that the kidney does as well. So the actual split function is 19% on the left and 81% on the right. Remember, we are imaging posteriorly, so left will be to your left and right will be to your right. Now, let's say on a dare, we take that normally drawn background and we superimpose it over the spleen. In that case, we have increased that background 1 for kidney 1 and therefore decreased the numerator. So our function is now 13% on the left and 87% on the right. So why is this important? Because this could lower the renal function below the threshold that the urologist may use to decide whether to salvage or to take out the kidney. And this could be anywhere from 10 to 20% depending on the urologist and the clinical situation. You may have also heard the term time activity curve. That is simply activity within a region of interest mapped by time. To the left, we see normal uptake, excretion, and emptying curve. Now, there are various types of abnormals, but do not bother memorizing these different types. Just understand why the time activity curve looks this way. So, for example, if a patient has a kidney with retained radiotracer, which does not empty, we could see an upgoing time activity curve, and that will be the type 3. If you have a poorly functioning kidney, you can understand why it might look like a type 5. There are also some numbers which are generated, and it looks daunting, but don't be confused. Let's just concentrate on the few important numbers we need to know. And just remember, the time activity curve reflects the images, and the numbers reflect the time activity curve. The first number we report is MAG3 clearance, and that is reported versus expected MAG3 clearance for age and body surface area. Now, this can reflect subtle parenchymal dysfunction, and the bottom line is it can be used to follow renal function if done at a single center with the same technique, so we report it. Probably one of the most important numbers we report is the uptake, and this is the split function. You want to look at this uptake line, not the perfusion indices, for example. This is calculated using whole kidney ROIs at peak maximal nephrogram, that is, after flow and uptake but before radiotracer arrives in the collecting system. And it's usually the integral of counts at approximately 1 to 3 minutes. Other indices we report is the time to peak, which is how quickly that maximal parenchymal phase occurs. And this should be less than 5 minutes, and this is based on the whole kidney ROI. And finally, the 20-minute to maximum activity ratio, which is how quickly the radiotracer transits through the parenchyma. In other words, if the tracer is transiting slowly, one can have parenchymal dysfunction. Now, the normal based on cortical ROI is less than 0.19, but if you take 0.19 plus 2 standard deviations, one can assume parenchymal dysfunction is present if these 20-minute to maximum activity ratio is greater than 0.35. We can also use the whole kidney ROI for this number as well. Here's a pro hint. If the time activity curve is upgoing, such as this curve, there's really no need to report time to peak or 20-minute to maximum activity ratio because it doesn't have much meaning in this situation. Just note in the report there's an upgoing curve. So let's look at our key indications of why we would do this exam. And we're going to go through each of these looking for relative function. Is hydronephrosis obstructive or post-obstructive? For renal vascular hypertension, transplant purposes, pyelonephritis or scar in the setting of UTI, and vesico-ureteral reflux. These top two are the main indications of why renal scintigraphy is performed today. First, let's look at relative function. We want to know, is the kidney functioning? The concept of functioning renal volume or mass. The bottom line is the kidney worth saving? Urology, as noted, often uses a 10 to 20% cutoff, but it depends on the urologist and the clinical situation. Overall, MAG3 is better to answer this question due to higher extraction. But you may use DTPA if you're doing a study in a healthy patient, such as a renal donor. So to look at relative function with DTPA or MAG3, we're going to use that integral of counts in the first 1 to 3 minutes, using a whole kidney ROI at the maximum nephrogram before a tracer appears in the collecting system. And this is typically picked by the program. The normal range is in the 42 to 58% split. So here's a patient with normal split function. And this is on an older system, but first, just look at the images. And we could see the renal activity is about equal. And when we look at the curves, they're about equal. And the relative uptake indeed is 52% on the left and 48% on the right. This is a patient with an abnormal split. Now look at these frames. All you really have to do is look at this image, and you'll see there's different functioning renal mass in each kidney. And that's reflected first in the kidney on the right, has a higher time activity curve, and the split is 73%. And on the left, there's less functioning kidney. We could see the curve is lower, and the split is 27%. That is the basics of looking for relative function. Now on to a common indication, which is hydronephrosis obstructive or post-obstructive? So why is this important? Obstruction will lead to a loss of renal function, which is why it is important to relieve. But a dilated collecting system or hydronephrosis can also be due to reflux, or it could be present after the relief of a prior obstruction, and that collecting system may never return to normal size. So the question is the obstruction active or not? Lasix renography is the best non-invasive test to determine if hydronephrosis is due to active obstruction. And this is based on stimulating high flow of urine with Lasix. So in other words, it's like a stress test for the system to determine if the collecting system can handle the high flow. And if it does, this effectively excludes obstruction. For Lasix renography, the consensus is to use MAG3 due to its higher extraction. Now there are many ways to time the Lasix, and one can give it 15 minutes before radiotracer, called an F-15 study, at the time of tracer, called an F=0 study, or at some point thereafter, F plus X, whatever time that is. Now some advocate 35-minute study with Lasix given 20 minutes into the study and additional 15 minutes of imaging. Yet, we know that the maximum Lasix diuresis is at 15 to 18 minutes. So in this case, you may not be giving the kidney enough time to have that full diuretic effect. Now, each of these techniques has its proponents. The important point is to be consistent, use a standard published protocol, and know the limitations of each. How do we do it at Emory? We do it with two separate acquisitions. First, we get a 24-minute baseline. Then the patient gets off the table and voids, and we get a post-void image, and then the images are checked. If the baseline is normal, there's a very high likelihood there's no obstruction, so Lasix is not needed, and there's nothing left in the collecting system to empty anyway. But if there is retained radiotracer, we give Lasix, and followed by a 20-minute dynamic image. This is done with the patient back on the table. Now this technique is more individualized. Lasix is given at maximal filling. There's also improved patient comfort and allows enough time for the Lasix to fully work. But this also takes longer and requires more interaction with the nuclear medicine physician. How much Lasix should be given? This is critical. The standard dose is 0.5 milligrams per kilogram or 40 milligrams in an adult, and 1 milligram per kilogram with a max 20 milligrams in a child. Remember, one must give a bigger dose if the GFR is decreased. At Emory, if the creatinine is less than 2, we give 40 milligrams, and if the creatinine is greater than 2, then we give 60 to 80 milligrams. One can argue if the creatinine is abnormal at all, one should give 80 milligrams. But remember, in a typical adult, you want to give minimum 40 milligrams. Also, be aware that a kidney with poor function may not respond to Lasix, so you also want to use gravity and post-void imaging when needed. And if the tracer washes out with Lasix or gravity, then the system's not obstructed. Sometimes you just can't tell, and then you should say so. Remember to use the appropriate region of interest, whole kidney or dilated collecting system. You don't want to use cortical region of interest or parenchymal region of interest here. You may have also heard the term diuretic T1/2 or T1/2 emptying, and this is simply the half emptying time from peak filling. Less than 10 minutes is normal, greater than 20 minutes is obstructed, and in between is a gray zone. But this is also dependent on the tracer, equipment, and protocol, and you just may need serial studies to establish if a system is truly obstructed. But most importantly, do not depend on the numbers alone. Look at those images. Always return to the images and the time activity curves. Also, look at the post-void images. If radiotracer empties post-void, even though it may have been retained earlier, but then you let the patient go to the bathroom and then you get post-void images, and there's no radiotracer left, then the system is not obstructed. Also remember, that if the collecting system emptied before Lasix, but Lasix was given anyway, the T1/2 may not be meaningful, as there was no radiotracer left to empty. So don't report T1/2 in that case, because it can be spurious. You also want to ensure the patient is well hydrated. It can cause a false positive if they're not. Remember that DTPA may not have the sufficient extraction to really show renal function as well, so it can look decreased. If the patient is emptying into a dilated bladder, it may look obstructed. Remember to have the patient void beforehand. Severe renal damage can cause a situation in which the kidney cannot respond to Lasix, so those gravity views can be helpful. And also grossly dilated pelvis may just take longer to wash out due to reservoir effect. So in that case, the T1/2 may be expected to be 15 to 20 minutes, and that's as good as the patient's going to get. So let's return to our earlier case. There was a question of obstruction. Let's play our dynamic imaging. We see the frames. There is uptake, excretion, and emptying, reflected in the time activity curve. Also, the post-void imaging has no tracer left in the collecting system. This patient does not need Lasix. There's nothing left to empty. There is no obstruction here. Let's look at another patient with a left renal cyst causing hydronephrosis, who is post-unroofing, and there is persistent hydronephrosis. Let's play our dynamic images. And we could see that while there is uptake, excretion, and emptying on the right, there is retained radiotracer in the proximal left collecting system, reflected in the upgoing time activity curve on the left. On the right, this is not a perfectly normal time activity curve, but there is emptying. Then 40 milligrams of Lasix is given. And we could see on the left that there is excellent washout of radiotracer, reflected in the downgoing time activity curve, and the diuretic T1/2 of less than 10 minutes. Thus, this is non-obstructive hydronephrosis. Let's look at another patient with left flank pain with ultrasound showing a dilated collecting system. We don't have dynamic images here, but we can see while on the right there is uptake, excretion, and emptying, on the left there is retention of radiotracer proximally, seen on the post-void image. There's an upgoing time activity curve on the left and a fairly normal time activity curve on the right. So what are we going to do? Yes, we're going to give Lasix. 40 milligrams of Lasix was then given, and we can see that there is retention in that left proximal collecting system with a flat time activity curve and the diuretic T1/2 of 41.8 minutes. Thus, this was UPJ obstruction. The patient subsequently went on to pyeloplasty and presented at a later time with some abdominal pain. A Lasix renogram was performed. First, we could see on the baseline the right kidney empties well, but that left kidney has retained radiotracer in the collecting system, seen on the post-void imaging. Time activity curve plateaus. Again, the right kidney has normal uptake, excretion, and emptying. So, is there obstruction? Did the pyeloplasty just not work? Again, Lasix was given, but this time we could see on the left there is emptying of that collecting system. Nice downgoing time activity curve. Diuretic T1/2 is less than 10 minutes, so this was non-obstructive hydronephrosis. I want you to note something. Look on the right. The diuretic T1/2 is 23.8 minutes. That's spurious. That right kidney had already emptied, so there's no use in reporting that. There's clearly no obstruction on the right. Remember, look at the images first and last. Most of the time, you don't need the time activity curves or the numbers to make the diagnosis. So let's look at this patient in baseline. And we could see there is retained radiotracer proximally on the right, while there is washout on the left. Then, we give Lasix, and there is still retained radiotracer in the right proximal collecting system. Therefore, this is obstruction at the UPJ. Let's look at another case of a patient with left flank pain. The patient is status post negative left ureteroscopy, then developed left flank pain. MAG3 renal scan was ordered. The urologist sort of volunteered on his own that the ureter was manipulated only very little. So let's look at our images. We can see, and the numbers are just taken from mid-study here, but the important point is that there's good uptake, excretion, and emptying in the right kidney, but the left kidney has uptake but no excretion. We just have an increasingly dense nephrogram. Remember, the time activity curve simply reflects the images. So we see that here in the upgoing curve, and no radiotracer appears in the collecting system. In this specific case, there is a differential involved. First, one wants to typically see radiotracer in the collecting system before giving Lasix. And in this case, with the patient in pain, we may just want to get delayed images, and that's what we did here. But what is the differential diagnosis of an increasing unilateral dense nephrogram? First, obstruction is the most common. There's so much pressure, the radiotracer does not even get into the collecting system. The second is renal vein thrombosis. And uncommonly, high-grade renal artery stenosis can look similar. Now remember that ATN and hypotension can cause an immediate dense nephrogram without excretion, but that is typically bilateral. So we did get 3-hour delayed views, and we could see the right kidney is long emptied, but the left kidney has persistent colonization to the distal ureter. The activity in the bladder is likely from the right kidney here, and this indeed was obstruction. And it turned out to be temporary spasm from the procedure, and the renogram was normal 24 hours later when it was repeated. Here's another patient with hydronephrosis on outside CT. The patient had abdominal pain, but then it was suddenly relieved. There's also a history of prior stones and hydronephrosis. Let's play our dynamic images. And we could see that while there is good uptake and excretion and emptying on the right, something strange is happening on the left. Lasix was then given, and we could see something really strange is going on. So what do we think is going on? Well, this was obstruction, but relieved due to perforation, and there is now extravasation, correlated nicely on CT with fluid about the kidney, and we could see a renal stone peeking in. And in truth, if this had been recognized as perforation on the baseline imaging, Lasix should not have been given. So we're going to move on to another key indication, and that's looking for renovascular hypertension. Now, this study is not ordered as much today, but it is worth reviewing since occasionally this can be performed, and understanding these principles help you also understand basic renal physiology. The general principle is that hypertension is so common, even in a patient with renal artery stenosis. The renal artery stenosis may be an innocent bystander to the hypertension, and that most stenoses do not actually require angioplasty. There is a high positive predictive value for renovascular hypertension if the study is used in a well-screened patient with normal renal function. We're going to give a shout out to Harry Goldblatt, who figured out that if you clamp one renal artery, this resulted in transient or permanent hypertension, which could be relieved if you either remove the kidney or simply relieve the stenosis. So let's understand the basic pathophysiology. Renal artery stenosis results in decreased perfusion distal to the stenosis at the afferent arteriole. This causes a decrease in the transglomerular pressure gradient, so you get a decreased GFR. This stimulates release of renin from the juxtaglomerular apparatus. Then renin cleaves angiotensin 1 from angiotensinogen, and then it's converted to angiotensin 2 by ACE, or angiotensin converting enzyme. This in turn constricts the efferent arteriole and restores the gradient and the pressure head. By giving ACE inhibitor, we block that restorative mechanism. Then the GFR drops again, and this is detected by a decrease in uptake compared with a baseline. So for example, a GFR agent like DTPA, you'd look for a decrease in relative function, or for a tubular agent like MAG3, you'd look for a parenchymal retention. And we'll be showing examples of this. And the reason why there's parenchymal retention is because the pressure head is decreased, so you're not pushing that tracer through the kidney. So how do we do it? First, if you're going to do this in your practice, refer to the Society of Nuclear Medicine guidelines to see what is best for your practice. There are differing protocols, but basically they all involve comparing a baseline to post-ACE inhibitor imaging, though you can start with a baseline or start with the ACE inhibitor imaging, and if that's normal, you could just then stop and never get the baseline. So it just depends. You want to stop captopril 3 to 4 days before the study, and longer acting agents 7 days before. Angiotensin 2 receptor blockers are okay. Ideally, you also want to stop beta blockers and diuretics 3 days prior to the study, though that's not as critical. Now, if the patient has normal renal function, you could use either DTPA or MAG3, but if there's any hint of unilateral or bilateral renal dysfunction, we recommend doing the study with MAG3. What we do at Emory is get a low-dose baseline first with 1 millicurie of MAG3. Now I have to mention that it is acceptable to give 25 milligrams of crushed captopril in water and then repeat the study 60 minutes post ingestion of the captopril. But at Emory, to avoid issues with variable gastric absorption, we give enalapril. We of course keep the IV line in place and monitor blood pressure in case of hypotension. Doesn't typically occur, but if it does, you can just increase the fluids. And then we give a second full dose, 10 millicurie radio tracer 15 minutes later. So how to interpret these studies? If your practice is doing these, it's best to read these guidelines for exact criteria. Unfortunately, this has been categorized as low, intermediate, and high probability in terms of interpretation. But do not panic or get caught up in these numbers. Looking at the images here is really key. First, if you're using DTPA, you're looking for a change in relative uptake over 10%, so that's pretty simple. For MAG3, you're looking for parenchymal retention compared to baseline. So if there's uptake but it's retained in the parenchyma with slow transit to the collecting system, this will cause a significant change in time to peak. It'll be prolonged, and that 20-minute to maximum activity ratio. Ideally, if there is a very positive study, it'll then look somewhat like a high-grade obstruction compared with baseline. So let's look at this 78-year-old male with a blood pressure of 230 over 120. First, our baseline. There is normal uptake excretion emptying. We could see it in the time activity curves. But after we give captopril, we could see the right is emptying, but the left just looks like it's retaining that radio tracer. The time activity curve goes high, and the time to peak as well as the 20-minute to maximum activity ratios are increased, and they're asymmetric. So this table refers to a unilateral change. Basically, if the baseline's normal and the post-ACE inhibitor scan is normal, the likelihood is very low, less than 10%. If the baseline's normal and then it becomes abnormal, the likelihood is over 90%. And if the baseline is abnormal and then it stays abnormal, that is indeterminate. But if it's abnormal and it becomes really abnormal, again, that is a high likelihood. Note that bilateral and symmetrical retention would also be abnormal, but it's unlikely to represent renovascular hypertension. So let's look at a case. 35-year-old, hypertension, MR showed 50% stenosis of the right renal artery. Is it significant? Let's look at our dynamic images. First at baseline, uptake, excretion, and emptying. So that's nice. Now let's look at our post-captopril imaging. While there is still uptake, excretion, and emptying on the left, there is now radiotracer retention on the right. And this is reflected by our time activity curves and numbers. Notice at baseline we have nice symmetric time activity curves. What happens post-captopril? The right kidney time activity curve goes high, and our numbers change. First, the time to peak at baseline and the 20-minute to maximum activity ratios were about equal. Notice the 20-minute to maximum activity ratio, both were slightly abnormal, but they were symmetric. But after we give the captopril, the time to peak on the right increases, and our 20-minute to maximum activity ratio also increases, and they become very asymmetric. Some pitfalls here. Remember, dehydration, low blood pressure can cause apparent abnormalities, and also not stopping medications like ACE inhibitors. Let's go on to some lesser used indications, such as for transplanted kidney. Now first, this study can be helpful for a donor situation to see which kidney has the better function to donate, but the use of this study varies between centers. For transplant itself, this study is not done as much anymore since ultrasound and biopsy are now considered the real gold standard here. First, if you do the study, remember to image anteriorly because that's where the transplanted kidneys are placed. You basically want to look for the kidney to light up at the same time as the iliac vessel. Now, classically, for ATN, you would have preserved perfusion with delayed uptake and excretion. Just note that severe ATN can also have decreased flow. For rejection, you would have diminished perfusion with delayed uptake and excretion as well. But note these patterns overlap, and that for chronic rejection, scintigraphy cannot reliably distinguish rejection versus calcineurin inhibitor toxicity. So just remember preserved perfusion versus diminished perfusion. Preserved perfusion indicates ATN, diminished perfusion indicates rejection. Today, this study is mostly used looking for obstruction and leak. This patient is status post-renal transplant with hydronephrosis with creatinine of 2.2. First, let's look at our vascular flow. And we could see that there is excellent vascular flow with the time activity curve of the iliac artery and the time activity curve of the perfused kidney very close to each other. Then we go on to the next phase of our exam, and let's look at our dynamic images. We could see that while there is good uptake and excretion, there is no significant emptying. A little gets in the bladder. There's an upgoing time activity curve, and on post-void images, there is retention of radiotracer without washout to the level of the UVJ. So what are we going to do next? That's right, we're going to give Lasix. And in this case, we'll give 60 milligrams of Lasix because of the elevated creatinine. Let's look at our dynamic images. We could see here excellent response to Lasix with washout from the collecting system, downgoing time activity curve, and diuretic T1/2 less than 10 minutes, and therefore this is non-obstructive hydronephrosis. Another key indication used really in pediatrics today is pyelonephritis or scar in the setting of UTI. DMSA here is the tracer of choice for cortical imaging, and we get static images then at 2 to 4 hours. This is most often done for pyelonephritis, acutely looking for upper versus lower UTI, and scarring post-UTI. So in general, for acute pyelonephritis, you would have an intact contour of the kidney but focal defects, and for scarring, you would have deformed contour. Sometimes the kidneys don't always read the books, but that is the general dividing line. But remember that any focal defect is not specific, as even a cyst will cause photopenia, so you want to interpret the study in context with other imaging. Here we have acute pyelonephritis in 2 patients. So on the left, that's a normal appearance. On the right, we see these photopenic defects. Here on the right, that's a normal cortical appearance, and on the left we see focal defect in the parenchyma. Here is a patient with both processes going on. First, we can use this study to do splits as well. And here we see multifocal scar on the left with this linear contour abnormalities reflected nicely in the ultrasound. And on the right, we see more focal defects also reflected in the ultrasound. Another indication for pediatrics is that of vesicoureteral reflux. Remember that the direct radionuclide cystography is a good radiologic VCUG alternative that delivers a lower radiation burden. Typically, 1 millicurie of tecprotecnetate would be instilled into the bladder. This does require bladder catheterization, but it's more sensitive than VCUG because the acquisition is continuous, both during the filling and the voiding phases, and it doesn't cost any more radiation to do that. There is a grading system, and you just may want to be roughly familiar with that. In this case, we have grade 3 reflux into the collecting systems proximally. And remember, expect the unexpected. Here we have a patient who had an enlarged prostate with a PSA of 128, and a bone scan was performed. Remember that the kidneys may be seen on many other exams, such as bone scan and FDG PET, for example. So what are the findings here? Well, first, we can look here at the bone, and we see there are metastases. But also, there's a unilateral intense right kidney compared to the left. Remember, bone scanning is done approximately 2 to 4 hours post-radiotracer administration. So we have a persistent nephrogram with that excretion. There is a differential, as we learned in this talk, but in this case, it is obstruction from the prostate cancer invading the right trigone, causing right hydronephrosis. So we're going to finish up with some questions. First, MAG3 is in which category of renal radiotracer? Glomerular, tubular, cortical, or vascular? And the answer is tubular. Question 2. DTPA is in which category of renal radiotracer? Glomerular, tubular, cortical, or vascular? And the answer is glomerular. Question 3. DMSA is in which category of renal radiotracer? Glomerular, tubular, cortical, or vascular? And the answer is cortical. Question 4. Which of the following is the most appropriate minimal typical adult dose for Lasix renography in a typical adult? 5, 10, 20, or 40 milligrams? And the answer is 40 milligrams. And our final question. An improperly placed background renal ROI can cause most likely which of the following? Spurious T1/2 emptying time, spurious split function, spurious time to peak, spurious post-void residual? And the answer is spurious split function. Thank you for your attention. And remember to view this talk at least a few times over the years of your training, and you will retain what you need to know.